The industry of over-the-counter female sexual wellness is $55 billion a year. Personal lubrication agents alone is $1.9 billion a year, what people are spending on that.
Welcome to HKB Uncut, the health, knowledge, and beauty podcast.
On this show, we unpack the newest techniques and trends in cosmetic surgery, how to tune out the social media noise to make empowered decisions about your appearance, and what you need to know before you book a procedure.
I'm Dr. Bill Kortesis.
And I'm Gaurav Bharti. We are board-certified plastic surgeons and co-founders of HKB Cosmetic Surgery, an award-winning practice with 11 locations across 6 states.
In other words, when it comes to aesthetics and cosmetic surgery, we've pretty much seen it all, and we want to share our knowledge and unique approach to aesthetics and beauty with you. Whether you're interested in cosmetic surgery for yourself or want to separate fact from fiction in the plastic surgery world, we hope you'll tune in each week.
We're so excited today about the episode. We're going to talk about labiaplasty, and we're going to be talking to our incredible partners in Nashville, Dr. Mindy Haws and Mary Gingrass. We're so excited to have you here today.
Thank you. Glad to be here.
We're super pumped to talk about female rejuvenation and anything else that's on your mind.
Absolutely.
Awesome.
I just was sitting on a panel at the big aesthetic meeting about female sexual wellness. And a couple of things to keep in mind. The industry of over-the-counter female sexual wellness is $55 billion a year. Personal lubrication agents alone is $1.9 billion a year, what people are spending on that. So we're really doing our patients a disservice if we're not doing something medical grade, because they're getting it somewhere.
Mm-hmm. How often are patients, requiring these type of interventions?
It's more and more.
More and more, and I think it's something you kind of have to elicit. Both Mary and I get a lot of patients who come in for labiaplasty, and I don't think there's much of a barrier there, Mary. I mean, I think we do.
No, I think that it's easy to research on the internet. People come in pretty well educated. We have a young population to an old population. There's lots of people doing that.
No, and not everybody likes to do that surgery. We do, and I think we do well with that population. We see them, but I think that there's still a segment of women who maybe aren't there for a labiaplasty, but are there for other female rejuvenation, vaginal rejuvenation. And those are the ones, I don't know that we're as good at eliciting that or asking about that or following once we do ask. Because labiaplasty, we can make it look better cosmetically. We can fluff up the majora. We can trim the minora. But we can also, we've got the Morpheus V, the InMode device, where we can tighten up that vagina. And we can help improve sexual response and help improve just the skin texture and tone non-surgically.
So if a patient's like on the fence of like, do I need this? Do I not need it? How do they know if they're a good candidate to go down this road and to actually pick up the phone and call you to discuss these procedures?
I think with labiaplasty, people are talking about it more, and it's really easy to research on the internet. So it's not nearly as taboo. It's also really a lot of people are talking about it more because everybody shaves their pubic hair. So it's kind of right out there front and center if women are dressing around each other.
Yeah, what Mary's saying, it's interesting because I think the misconception is that women are doing this because they want it to be prettier. And there is a little bit of that, but I think a lot of it is really
for sure.
Collective complaints about it's hard for me to wear workout pants because as Dr. Gingrass said, everybody's grooming down there. That didn't used to be a case, right? And so when people had a lot of pubic hair, clothes were made differently. So you couldn't see the pubic hair, and therefore you weren't going to pinch your labia minora if it hung out. Now with no pubic hair, everything is so thin. I see women all the time who have to tuck their minora inside to look okay in a bathing suit.
Right. Yeah, I hear that complaint a lot. The young girls especially, they're like, I'm embarrassed to wear a bathing suit, like a bikini, or it has to be like a full coverage bikini.
Yeah.
They have to shop around. If they're shopping around it, it's time to look into options.
What and when you all do these, are they typically in isolation, or are you combining with others? Like, what's the typical patient, or can it be both?
I would say the young people, it's in isolation, and we can do it under local anesthesia. So it's particularly advantageous to do it just a labiaplasty, unless there's something else you can do, like upper eyelids under local anesthesia. But the weight loss patients are another kind of high yield population, and they often are having more than one procedure. So you just have to take each individual patient as they come in and make your recommendations, accordingly.
What techniques do you all do?
If that's all they want, it's really easy to get that area completely numb and have them very comfortable. Do it under local, which is nice.
Yeah, we just numb it up ahead of time. So when the numbing medicine is injected, they're pretty much, 90%
Yeah.
numb anyway. And, we're sitting there talking about the weather or kids or, what podcasts are you listening to or what Netflix are you? So it's a very, almost everybody says, oh my God, that was so much easier than I thought. Oh, what was I worried about?
Along those same lines, what's the recovery like?
It's a pretty easy recovery. We just say ice is your friend. So I would say for 48 hours, max 72, you should plan to kind of hang out at home and ice. But you can absolutely be up and around and moving. It's just you don't want it to if it swells too much in those first couple days, the recovery gets longer. But it's a back to work in a couple days surgery.
And really, if people need pain pills, and not everybody does,
Not everybody does.
it's the first 12 hours. And it's usually, I always tell people, if you've ever had dental work, sometimes when the numbing first wears off, you get like this incredible kind of neurologic burning, these paresthesias. And since it's all mucosal tissue, every once in a while people will get that lasts a couple of hours. But then after that, it's an area of the body. If it didn't rebound really quickly, women would stop having babies. It's an area that's built to heal really well and really fast.
And in terms of limitations, post-op, like what are their limitations and for how long?
I mean, don't get your blood pressure up. Don't strain. Ice.
I tell them not to have sex, not to ride a bike, not to run, or probably the
And
first,
garments wise.
and garments. Watch anything with the central seam for a couple of weeks.
What's
You're
your
not going to be wearing a thong for a while.
what's your insertion timing? Nothing inserted for how many weeks? 6 weeks, 8 weeks?
Oh God, no, 3 weeks.
Us?
3 weeks. Okay.
It just depends. If they're a big clitoral hood and menorah, or if we go around the perineum,
It's more.
longer. But I can't tell you how many 60-plus-year-olds I see, and at 2 or 3 weeks, I'm telling them they can start easing back into more activity, and they're like, "Honey, I'm already there."
I tell people 6 weeks for sex.
Yeah. Will you all kind of get into the nitty gritty about the technique that you guys like and why and what the other techniques are?
I'm an
I mean,
unapologetic.
there's two.
Yeah, there's two basic techniques.
There's the trim and the wedge.
Mm-hmm.
I'm a trimmer too. I mean, I take each individual patient. If they have just a little bit of central redundancy and everything else is fine, then they might lend themselves to a wedge. But I feel like I can never get enough. And people, they want to see a difference. And it doesn't affect your ability to lubricate. It doesn't affect your ability to orgasm. It's just skin that's hanging out anyway. So you're just getting rid of what's redundant. And this is a really, really happy patient population.
How often are you doing the external with the internal? Because you mentioned, doing laser for internal tightening. So how often are you doing a combo, or are they isolated procedures?
We're not doing them at the same time. So we kind of isolate them separately because we're doing one set in the OR. And then if they want to do the vaginal tightening, that's separate. And not everybody wants vaginal tightening
Needs a labiaplasty.
plastic.
And vice versa.
Yeah. And the other thing with the trim is that the argument for doing the wedge technique is you keep the pigmented edge of the menorah.
But
And
nobody
I've
wants
yet
that, right?
say, I really like that pigmented
Yeah,
edge.
I've never heard anybody want
Nobody.
that.
Please, God, get rid of that.
Yeah.
But it is
Yeah.
technically, you're not just lopping it off. You've got to design it so it flows in with the rest of and it took me a couple of years to figure that out. But
It's a really variable. The anatomy down there is so variable. It never ceases to amaze me how different people look. And I especially with the young people, I start the consult out saying, you know, you're normal. There's nothing abnormal here. It's just it's just you don't like the way it looks. A big hook nose is completely normal too, but doesn't mean you have to go through life with a big hook nose when you can alter it and be more comfortable with yourself and in your own skin. And it's a really, really happy operation.
I agree. I
You know,
agree.
I would say that I don't do this as high volume as you all do, but I have done and do a fair amount, and so do our other surgeons at here in the Charlotte area. But the interesting thing about this procedure, at least from a surgical standpoint, is that I'm telling you, man, patient satisfaction. I mean, it's like through the
Yeah,
roof.
it's
Even
very high.
even if there's like a little micro issue or something, they would be like, "I'll do it all day long." So I think
Yeah.
there are a lot of things like that in plastic surgery, but this one is like really, really, really high, and it always impresses me.
I think it's kind of like breast reduction and gynecomastia. Patients don't come in for this unless they're really, really sure they want to do it. That there's that initial barrier that keeps you from getting a patient who may not be satisfied because they have researched it, they have geared themselves up, which is why they're also a high schedule rate, right? Because they're really
Yeah.
they're really invested by the time they make it to the office.
Do you see any complications or problems with the procedures? And are revisions something that people often get for these cases?
Revisions are rare, very rare. I've done a few revisions from the outside. The revisions I've done on my own patients have usually been a stitch that came apart a little too early and left a little, notch or something that just needed to be cleaned up. So never believe a surgeon who says I never have complications, but it's a pretty kindly healing procedure. But there are revisions. There are some people who had problems and come in for a secondary opinion, and sometimes you can help them, sometimes you can't. It's if you take too much out, you're stuck.
Yeah, and I think it's also about patient communication, right? Because the patients that I've had who've every once in a while there's a revision, just one edge, or it's not quite as, and you're never going to get complete symmetry in this area. And
Never.
I think once they've been so asymmetrical, they really, really want to be symmetrical. There's a little bit of that. And like Mary said, maybe a wound edge. I've had one healing problem like in 20 years of doing these. We do probably
Yeah, it's
15.
rare.
It's rare.
We do all absorbable sutures,
Mhm.
so they come in at a week and have anything that hasn't dissolved yet in a week. The nurse will just snip out, and then they see us at 2 weeks. And for the most part, they're healed. Like they're rearing and ready to go. And almost everybody says this was so much easier than I thought. Just like breast augmentations, they you get yourself so worked up about it, and almost everybody walks away and says, "Oh, that was way easier."
Very similar, I think. I think
Especially doing it under local.
there's also that patient population that has a very enlarged clitoris, but has a really full clitoral hood.
Mhm.
So, and we all learned doing these that if you have a long clitoral hood and you only trim the menorah, then you get almost like a penis deformity where it looks even longer than it is. But some women with a really long, very prominent clitoris, you can't trim that back as much as you would like.
No,
You denude the clitoris, and then you can't wear tight.
right.
So I think
Nobody's happy.
there's some patient education about how much you can and can't do and what restrictions there are of the anatomy. And I know there's a couple people in the US who will actually do like clitoral setbacks.
Mhm.
I think that's
Yeah.
is the way of a fool. I would not risk that for
It may be great in somebody's hands who does it all the time, but
I would not advise it in my hands. I
I
just
start every consult. I do every consult with a mirror.
mm,
So I'm explaining their anatomy, showing them exactly what's going to be trimmed off, what can expect that it's going to look like. I show them, this is your labia minora, this is the labia majora, this is your clitoral hood. This is why the clitoral hood is important. And, you know, sometimes they have a lot of perineal redundancy, oftentimes they don't. And, you know, just looking very specifically at their anatomy and finding out what their concerns are, and then talking about what can and can't be done, or should and shouldn't be done.
You know, there's some cases where when patients have had like pretty significant tears on delivery and episiotomies, what do you all do? Do you all manage that posterior aspect? And if it is, you know, significantly extended and kind of deepened almost to the level of the anus, will you all do some approximation, or can you talk to the listeners about kind of what can be done there so that they can have just a narrower entry point?
I mean, that's really more getting into vaginal tightening. And if they've had, you know, great, like big time tears, usually I would combine that with our urology friends. And it, most of the time they've addressed that with other doctors. So it isn't something that we specifically have gotten into, but we absolutely have people we can refer them to. But I see more minor tears all the time, and a lot of it's really easy to fix. People ask if you can fix their hemorrhoids, and I said no.
Well,
I draw the line there.
draw the line there. I draw the line there. And I agree with Mary.
You wouldn't want me doing your hemorrhoids.
We have a really nice female urology group like down the street from us. That's 3 women.
Yeah.
They do this a lot, so we don't see that much. And usually what I tell them is if I can't see it, I can't fix it. And because every once in a while I get somebody, and typically it's an assault victim who feels like
Yeah.
things are stretched out and I can't really even see what they're talking about or evaluate that. And then I send them on to the urology group.
Yeah, there can be a lot of social and psychological overlay to these procedures. So it's, again, really important to talk to each individual patient and see what their motivations are. And, you know, there's a young population that comes in too, that you do have to be careful. This isn't really for someone under 18. And if someone's under 18, they have to have their parent there.
Right.
But you're not even really fully developed. So
I had once an 11-year-old, I think she was 11, she might have been 12, who was sent to me by the pediatrician, who was a really great volleyball player, but had a menorah that hung like 6 centimeters outside her jaw, and she couldn't wear the volleyball the spandex that they wear for their shorts. It just wasn't possible. And so that was a long conversation, but even she was able to do it under local. So it's, you know, sometimes it's about correcting an issue. You know, the other thing, do you guys have that book, the Petals book in your office, the coffee table book that's called Petals? It was done, and I'm pretty sure this is in the intro, the front of the book, by a photographer and his son in the Bay Area. And all it is pictures of numerous labia, minora, and majora, the lithotomy view, like page after page after page. And we have that.
yeah, so it shows the variability.
It's a great thing to say, you are normal, but we fix normal all the time if you're not happy with your normal. But it does kind of help for those people who feel embarrassed or feel, oh, there's something wrong with me. It's not wrong, but it doesn't mean you can't fix it.
And it is interesting. I mean, you guys have probably seen it where there will be such significant asymmetry where one side is huge and the other side is essentially, quote, maybe more anatomic. Is it common to do just one, or do you always do the other side? What are strategies there?
I would say 10%. That's pretty common.
Yeah. Yeah. And you know, I usually take, even if I just take the edge of the mucosa off the other side, just because I think the surgerized edge of the mucosa looks a little different from that you can't really see the scar, but it just looks a little different. I think it makes it look a little better, even if I'm just taking off a couple of millimeters. But, you know, and to your point, G, it's interesting because you would think this would be a natural fit for gynecologists, but it really isn't. They're busy doing other things. They see so much anatomic variability. They're not concerned with, they're like, you're perfectly normal. And, you know, we see women in their 50s all the time who have some pretty tough asymmetry that they're trying to sit on or be comfortable with, that they've dealt with their entire life or their entire adult life.
I would say most of those significant asymmetries are postpartum. where one side just got more swollen or just babysat more on one side.
And it seems to be it's either postpartum or it's just it was always like that. I've had a couple of 22-year-olds come in with their moms, and the mom's like, "This has been hanging out since she was 5 years old playing Barbies. This is just who she is. This has nothing to do with puberty."
But isn't that everything we do, by the way? Is it nothing symmetrical?
Nothing
Like
symmetrical. You're right.
Nothing symmetrical.
And it could be one
They're
off.
sisters. They're not twins.
That's right. And the worse the asymmetry, the harder it is to deal with, right? I mean, people will deal with really, really low hanging breast easier if it's both sides than if it's just one side.
which it's interesting. So I assume you let them know this is going to be better. They're not going to be identical, right? Well, what's the takeaway with that? I mean, because that's what we tell patients with breast surgery. It's like, hey, we're going to get their asymmetry as close to each other as possible, but it's never going to be identical.
It's very rare. I'd say they're very realistic. These are just normal people that aren't like doing any kind of filming or, anything down there other than they just want to be more comfortable in clothes and maybe feel more comfortable in their own skin during intimacy. And it's very rare where people are expecting symmetry or perfection. They just want it to look better and feel better.
And you have Majora, adjacent to it, kind of shielding it when you're in the standing position. So at least I think a lot of them just don't want it hanging out.
Exactly. And your point, I think you have to examine them both sitting with their legs up, but also
sitting and standing.
And that's also where you can really pick up if that clitoral hood is going to be giving you problems later. And some women's Majora really don't come together at the front. There's always separation. And I think before and after pictures are important so they can understand that we're not going to completely, just like we can't put breasts right next to each other if they have a really wide cleavage line. Some of it is your inherent skeletal asymmetries.
And there's a lot of variability in Majora too.
Yeah, a lot of it.
And we do some fat injection, even some alloclay injection, but it's really a separate issue.
And you would think there would be more of them we do at the same time. And I think that's almost the exception rather than the rule.
Yeah, I would say it's for sure in my practice.
Well, guys, this is a wonderful discussion, and sounds like the takeaway is that, I don't know, this is a pretty straightforward procedure that really makes a lot of your patients very happy.
Very
happy.
And I think for our listeners, if there are any questions about this, please reach out and we'll make sure that they get answered. And we thank you all very much for tuning in.
Perfect.
Yeah, thanks for having us. We'll do it again sometime.
Thank you for listening to HKB Uncut. If you enjoyed this episode, please subscribe to us on Apple, Spotify, or YouTube.
To book a surgery consultation or med spa appointment with our team, visit our website at hkbsurgery.com or head to the links in our show notes.